Right now, somewhere in your medicine cabinet, there may be a pill that is quietly working against your memory. It is not doing this because it is dangerous in the way a warning label usually means, but because almost nobody explains what it is actually doing to your brain when you pick up your refill at the pharmacy drive-thru. By the end of this presentation, you will know exactly which medications carry that specific cognitive risk, what the actual published research says, and, more importantly, what to do about it without ever stopping anything on your own. Today, we are going to walk through a comprehensive countdown of 9 medications and drug classes most closely tied to memory loss, confusion, and accelerated cognitive decline in seniors. We will start with the everyday over-the-counter pills that get completely overlooked and work our way down to the single medication class I consider the most important to understand. And the most dangerous entry on this list, sitting at number 1, isn't a single drug at all. It is a mathematical reality that almost no single doctor calculates for you, and it may be sitting in your medicine cabinet without you ever realizing it is there. It is very common for people to accumulate prescriptions over time, adding a new pill for a new symptom without ever subtracting the old ones, resulting in a clinical phenomenon known as polypharmacy. This happens easily when you see multiple specialists, a cardiologist for your heart, a urologist for your bladder, and a podiatrist for your feet, each focusing brilliantly on their specific organ system, but not necessarily looking at the total chemical soup being mixed in your bloodstream. Before we start the countdown, we have to establish one vital piece of vocabulary that makes the rest of this breakdown make complete sense. A massive percentage of the drugs we are going to discuss operate by blocking a specific brain chemical called acetylcholine. Think of acetylcholine as the high-speed internet cable of your central nervous system. Your brain relies on it heavily to encode new memories, maintain focus, process surroundings, regulate your internal clock, and drive learning. Block it occasionally for a day or two, and the effect is minor. You might just feel a little drowsy or experience a bit of a dry mouth. Block it daily, for months or years at a time, especially from more than one source at once, and the cumulative toll is what researchers call anticholinergic burden. Keep that phrase in the back of your mind. It is the thread that ties all 9 of these entries together, acting as a structural weight that slows down neural transmission across the entire cerebral cortex. Number 9 is Diphenhydramine, the pill in almost every single medicine cabinet. You know this drug by its primary commercial drugstore name, Benadryl. But it is also hidden as the primary active ingredient in countless allergy pills, over-the-counter sleep aids, and nighttime pain relievers labeled as PM formulas. Because you can buy this drug without a doctor's signature at any grocery store or gas station, most people naturally assume it is entirely safe and gentle. It is anything but gentle on an aging brain. Diphenhydramine is a first-generation antihistamine with exceptionally strong anticholinergic activity, and it crosses into brain tissue with incredible ease because it dissolves so easily in fats. A landmark longitudinal study published in JAMA Internal Medicine followed over 3,400 adults aged 65 and older for nearly a decade to see who developed dementia. The results shocked the medical community. Individuals with the highest cumulative use of strong anticholinergic medications, with over-the-counter diphenhydramine prominent among them, faced a 54% higher risk of developing clinical dementia compared to those who used little or none. Consider a practical example. A 72-year-old retired schoolteacher starts taking an over-the-counter PM pain reliever every night to help with mild physical discomfort and occasional insomnia. Within a year, her family notices she is misplacing her keys daily, repeating questions, and struggling with basic tasks. They fear early-stage Alzheimer's disease, but the true driver is the full dose of diphenhydramine entering her brain every single night. When the brain is saturated with this drug during sleep, it disrupts the deep sleep phases necessary for memory consolidation, meaning the brain never gets to clear out daily cellular waste properly. Over time, this chronic suppression of acetylcholine prevents the brain from performing its nightly maintenance, leading to daytime grogginess that replicates early cognitive decline. The strategy here is not panic, it is clinical awareness. If you reach for a PM product or an allergy pill nightly, ask your pharmacist or physician about modern, newer generation antihistamines like loratadine. These are specifically engineered not to cross into the brain the same way, leaving your memory chemical alone. Never stop a vital medication on your own. Always bring your complete list to your doctor first. Number 8 takes us to proton pump inhibitors. These are drugs like omeprazole, esomeprazole, and lansoprazole, taken by millions of seniors daily for acid reflux, chronic heartburn, and indigestion, often for far longer than originally intended. Many people start taking these for a temporary bout of gastritis and end up staying on them for a decade because no one tells them to stop. Here the science is genuinely unsettled and evolving. The alarm bells first rang loudly in 2016 when a widely cited study published in JAMA Neurology followed over 73,000 older adults and found that regular users of proton pump inhibitors had a 44% higher risk of dementia. That study got enormous public attention and caused a wave of anxiety worldwide. But scientific research since then has been far less consistent. Several large cohort studies and a comprehensive meta-analysis found no reliable direct link once other health and lifestyle factors were accounted for. The honest summary is that this direct connection is still being actively debated by medical researchers, not settled. However, there is a secondary, indirect pathway that is completely undisputed, and it matters immensely for your memory. Chronic, long-term acid suppression can drastically reduce your body's ability to absorb vitamin B12 from your food. Your stomach requires a highly acidic environment to free vitamin B12 from the proteins it is bound to in your diet, so that your small intestine can absorb it. When that acid is gone, the B12 passes through your system unabsorbed. A profound vitamin B12 deficiency causes neurological issues like brain fog, severe memory gaps, mood swings, and concentration problems that look exactly like early dementia. It can even lead to structural damage in the myelin sheath, which is the protective insulation coating around your nerves. This can manifest as peripheral neuropathy, causing a distinct tingling or numbness in your hands and feet. The massive difference between this and a structural brain disease is that a B12 deficiency is completely reversible once corrected with targeted supplementation or high-dose injections. If you have been on a proton pump inhibitor for years for something that started as a short-term problem, make sure to ask your doctor to test your vitamin B12 levels. Number 7 brings us to bladder anticholinergics, which present real relief but a real trade-off. Medications like Oxybutynin treat an overactive bladder, which is a genuinely disruptive, isolating, and stressful condition that can completely rule a person's life. The physical relief these drugs provide is completely real, but they work by blocking acetylcholine directly, and they cross into the brain readily because of their molecular size. A massive study published in JAMA Internal Medicine examined nearly 59,000 people with dementia against more than 225,000 matched controls. They found that bladder anticholinergic drugs were associated with a 65% higher odds of dementia at the highest exposure levels. Furthermore, a drug-specific analysis looking at oxybutynin on its own found roughly a 30% increased risk of cognitive decline even at moderate, sustained use. The problem is that older molecules like oxybutynin do not differentiate between the acetylcholine receptors in your bladder muscles and the acetylcholine receptors in your hippocampus, which is your brain's primary memory bank. It shuts down the receptors uniformly, drying up your bladder symptoms while simultaneously starving your memory pathways. But the exact same research found that not every overactive bladder medication carries this severe brain risk. Several options, including darafenacin and trospium, showed no significant association with dementia because they are designed to be selective for the bladder or are physically unable to cross the blood-brain barrier. Trospium, for instance, has a specific structure that gives it a permanent electrical charge. This charge acts like a security guard, preventing it from passing from the bloodstream into the fatty tissue of the brain. Additionally, a newer medication called mirabegron works through a completely different non-anticholinergic pathway, targeting beta-3 adrenergic receptors, and is increasingly used as an alternative. If you have been on oxybutynin for a long time, that is a specific, evidence-backed reason to ask your doctor about switching to a brain-safe alternative. Number 6 is antiepileptic drugs, a very quiet inclusion. These are medications originally developed for seizures, like carbamazepine, topiramate, and phenytoin. This is one of the least discussed entries precisely because patients rarely connect a seizure medication to memory, especially since they are heavily prescribed off-label to older adults for diabetic nerve pain, peripheral neuropathy, shingles pain, chronic migraines, or complex mood stabilization. The same large-scale clinical studies found that older antiepileptic drugs with secondary anticholinergic properties were associated with up to a 39% higher odds of dementia at the highest exposure levels. Because these medications act as central nervous system depressants to stop an overactive nerve from firing off a pain signal, they can also slow down overall processing speeds in your brain, making word-finding and short-term recall much more difficult. Patients often describe this as feeling like their thoughts are wading through molasses or experiencing a frustrating tip-of-the-tongue phenomenon where they know a word but simply cannot retrieve it. Number 5 brings us to benzodiazepines, where we must be extra careful and precise. This class includes highly prescribed anxiety and sleep medications like lorazepam, diazepam, alprazolam, and temazepam. We must rigorously separate two completely different clinical issues: short-term side effects versus long-term dementia risk. The short-term cognitive effects are not in question. Benzodiazepines reliably cause slowed thinking, spatial confusion, and temporary memory gaps while you are taking them, and that risk is significantly higher in older adults, alongside a dangerous increase in the risk of physical falls. This happens because these drugs enhance a chemical break in the brain called GABA, which essentially turns down the volume on all brain activity, including the electrical signals required to form new memories. The long-term question of whether they cause structural dementia is genuinely less settled. Older analyses found an association, but more rigorous recent research found the link weaker and less consistent once they controlled for the fact that early, untreated anxiety and severe insomnia are often the first warning signs of dementia itself, rather than a result of the drug. What is absolutely not in dispute, regardless of how that debate eventually resolves, is this vital rule. If you have been taking a benzodiazepine daily for more than a few weeks, never stop taking it abruptly on your own. Doing so can cause severe, immediate medical emergencies, including dangerous blood pressure spikes, profound confusion, hallucinations, tremors, and physical seizures. Your brain becomes physically dependent on that chemical break, and removing it instantly causes a massive, uninhibited neurological storm. Any change needs to happen as a gradual, slow taper, planned directly with your physician over weeks or even months to allow the brain's baseline chemistry to restabilize. Number 4 is tricyclic antidepressants. One pill with 3 completely different reasons it gets prescribed. Amitriptyline is an older antidepressant that is still widely prescribed today, but rarely for depression. Instead, it is used at low doses for nerve pain, fibromyalgia, migraine prevention, and as a powerful sedative for chronic sleep issues. That versatility is exactly why so many seniors end up on it without ever being told it is one of the most strongly anticholinergic medications still in common clinical use. Large-scale medical analyses found that anticholinergic antidepressants as a category were associated with a 29% higher odds of dementia at the highest exposure levels. Amitriptyline acts like a heavy blanket over your brain's memory receptors, leading to severe morning grogginess, mental fog, and physical side effects like severe dry mouth, constipation, and blurry vision. This creates a state where an older adult feels cognitively impaired simply because their baseline alertness is constantly depressed. If you take amitriptyline for chronic nerve pain or sleep, do not stop it suddenly, but bring it to your doctor's attention and ask about safer, modern alternatives that do not carry the same heavy anticholinergic load. Number 3 is the specific medication paroxetine, widely known by its brand name Paxil. This is prescribed to millions of people for everyday anxiety and depression. Paroxetine belongs to a modern class of medications called SSRIs, which includes famous drugs like sertraline and escitalopram. Because SSRIs are generally considered a much gentler, safer category of antidepressant, doctors and patients assume they are all completely interchangeable when it comes to side effects. Here is the crucial detail that rarely gets mentioned. Among all modern antidepressants, paroxetine is specifically recognized in pharmacology research as having meaningfully stronger anticholinergic activity than its sibling medications. That single hidden property is exactly why the American Geriatrics Society publishes the Beers criteria, a formal clinical reference flagging medications considered potentially inappropriate for older adults. The Beers criteria explicitly lists paroxetine as a drug to generally avoid in seniors when alternatives exist, because its unique molecular structure presents unnecessary risks to memory and can cause urinary retention and confusion. If you take paroxetine, ask your doctor about switching to a cleaner alternative like sertraline or escitalopram that will treat your mood without taxing your memory reserves. Number 2 brings us to antipsychotic medications, which are prescribed much more quietly than you would ever think. This includes drugs like quetiapine, risperidone, and olanzapine. While they were developed for serious psychiatric conditions like schizophrenia, today they are frequently prescribed off-label to seniors at low doses for severe sleep problems, acute restlessness, or the intense agitation related to dementia itself. This often happens in overwhelmed care settings or home environments where family caregivers are completely exhausted and running out of options to manage difficult behavior. This is the single most strongly associated category in the entire landmark dementia study, where antipsychotics carried a 70% higher odds of cognitive decline at the highest exposure levels. Beyond that, the FDA has issued a black box warning stating explicitly that using these medications for dementia-related behavioral symptoms in elderly patients carries an increased risk of stroke and death. These drugs profoundly alter multiple chemical pathways in the brain, including dopamine and serotonin, and in an older brain that can severely disrupt homeostasis, resulting in a state of chemical restraint that accelerates decline. If you or someone you love is taking one of these medications, the single most important question to ask the prescribing doctor is direct. Why was this started? Is it still necessary? And can we attempt a slow, structured taper?
Many behavioral symptoms can be improved through non-drug approaches first,
Like treating underlying physical pain, establishing consistent routines, ensuring proper lighting to prevent nighttime confusion, and reducing overstimulation. We have reached number 1, and it is not a drug. It is the math that almost nobody does. You were probably expecting one final, single worst medication name. The real answer is far more important than any one pill. It is cumulative anticholinergic burden, the combined compounding effect of multiple anticholinergic medications taken together, where no single doctor necessarily adds up the final total. To visualize exactly how this math works, clinical researchers created a specific medical tool called the Anticholinergic Cognitive Burden Scale. Under this framework, medications are categorized to understand how quickly these numbers stack up in an everyday medicine cabinet. Drugs are given a score from 1 to 3 based on how heavily they block acetylcholine. A score of 1 represents mild risk. These are medications that have documented anticholinergic activity in lab settings, but their physical side effects are usually mild on their own. This column includes drugs like the beta blocker atenolol, the blood pressure medication captopril, or even low-dose risperidone. A score of 2 represents moderate risk. These are drugs where the blocker effect is more pronounced, such as the antiepileptic drug carbamazepine. A score of 3 represents severe risk. These are the heavy hitters. This column includes medications like the bladder treatment Oxybutynin, the antidepressant Paroxetine, and antipsychotics like clozapine, olanzapine, or quetiapine. The vital takeaway is that the danger is entirely additive. If you are taking 3 different medications that each have a mild score of 1, your total anticholinergic burden score is 3. In clinical studies, a total score of 3 or higher across your entire daily regimen is the exact threshold where researchers observe a statistically significant decline in cognitive performance and a measurable increase in long-term dementia risk. Picture a common, realistic scenario that happens to thousands of older adults. A senior takes over-the-counter diphenhydramine nightly for sleep, Oxybutynin daily for bladder control, and Amitriptyline for nerve pain. Each of these drugs might be prescribed by a different specialist, a primary care doctor, a urologist, and a pain management expert. Individually, a doctor prescribing just one of these might see a modest, acceptable risk. But inside the body, those medications flow into the exact same bloodstream and block the exact same memory receptors. The side effects compound exponentially, creating a profound chemical fog that can completely mimic advanced cognitive decline. When researchers looked at total anticholinergic exposure across all drug classes combined, they calculated that roughly 10% of all dementia diagnoses could be statistically attributed to cumulative anticholinergic drug exposure overall. That means 1 out of every 10 people sitting in a memory clinic right now might be experiencing a decline driven by the hidden math in their medicine cabinets. And here is the genuinely hopeful, empowering part. Cognitive decline caused by medication burden is often entirely reversible when caught early. This is not permanent structural damage like late-stage Alzheimer's. It is a chemical blockade. Reducing unnecessary anticholinergic load under strict medical supervision has been shown to give patients a profound, measurable upgrade in daily alertness, word recall, and short-term memory performance. The human brain is remarkably resilient, And once you remove the chemical weight that is pressing down on the acetylcholine system, the neural pathways can begin to communicate at their normal, native speeds again. The action step is simple, and it does not require a single new prescription or expensive supplement. Gather every single thing you consume for your health, every prescription bottle, every over-the-counter allergy pill, every sleep aid, and every vitamin. Place them into a bag, take them to your primary doctor or your local pharmacist, and ask for a complete medication review. Tell them you want to calculate your current Anticholinergic Burden Score using a formal clinical scoring tool. They can help you safely substitute higher-risk drugs for modern, brain-safe alternatives without compromising your physical health. Please prioritize having this conversation with your healthcare team this week. Thank you for listening today. Stay safe, stay informed, and take control of your health.